carve-out, carving out the behavioral health services from the rest of the health services funded through medical assistance. And of course, Cumberland County teamed up with Perry, Lebanon, Lancaster, and Dauphin to form a regional collaborative and our own management organization, the Capital Area Behavioral Health Collaborative, to manage the program on our behalf. Just a reminder, we covered some of this information recently when we were talking about going to a single contract. But just a reminder of the scope, first of our 5-county program. For the calendar year 2017, there were 263,000 plus residents who have medical assistance and had their behavioral health benefit managed by our 5-county collaborative. A little over 49.5 of those residents actually receive services for what we refer to as a penetration rate of 18.8%. And you can see the breakdown between the numbers receiving drug and alcohol and the numbers receiving mental health treatment and case management services. And of course, some of those overlap because there are clients that receive both and co-occurring substance use disorders and mental illness.
This is the 5-county region.
This is a 5-county region, yes. I'll get to our numbers in a second. And then the total dollar value of that was, I think that's a typo. I think that should be 251. Because if you add those two together, that's I think. So the total dollar value, and I just mentioned that again, just to give you an idea of the magnitude of the program. This is over $250 million in services paid for across the 5-county area. For Cumberland County, 38,000 plus residents of Cumberland County were medical assistance recipients. At some point during 2017, 7,200 of those received behavioral health services for a very similar penetration rate, 18.9%. And the dollar value of those services was $29 million. And there's the breakdown between drug and alcohol and mental health. And as a reminder, none of that is county money. All of that is state and federal money paying for these critical mental health and behavioral health treatment services for our residents, for Cumberland County residents. This complements the services that we pay through our PACE-funded Drug and Alcohol Commission and MHIDD program. I have the numbers just as a quick reference for Perry County. 9,000 residents were MA eligible. 1,600 received behavioral health services. Similar penetration rate again, 18.5%. And there's the breakdown between drug and alcohol and mental health. Total value of that, $6.4 million. Again, none of this is county money for the Perry County General Fund. And all of this is in addition to the capped funding that we manage out of our MHID and our DNA offices. So here's what we're really here to talk about. We were surprised to learn in December that some legislators were circulating a co-sponsorship memo to put forth legislation that would end the carve-out. It would end the county's right of first opportunity to manage the behavioral health part of medical assistance.
Jack, real quick, do most counties take that right of first opportunity?
Yes, I think there's only one county that's declined.
Yeah, I figured they could. Thanks. Why would anybody decline?
It was Greene County, sure whether they're really part of Pennsylvania. I'm just checking. They're down there near West Virginia and Ohio. And I think what it was is that they had so few lives, and they weren't confident that they would have the resources to manage it. But I don't really understand it because the rest of the counties in that area, Washington County just above them, entered into a collaborative similar to ours. They were referred to as for a while as the six-pack. And we thought, that's not really a good name for a behavioral health.
Yeah.
So now they're the Southwest Six.
Okay. But green is not part of that.
Green is not part of it.
They're using what, an MCO then for the,
Yeah, what happened is the county contracted directly with an MCO to manage the services for Greene County. And so Greene County doesn't have any control of that. They were cut out of the management. So the specific bills that have been introduced, I think in January, were House Bill 335, and the primary sponsor for that is Representative Seth Grove from York County. And then Senate Bill 268. And the primary sponsor for that is also from York County, and I forget her name. She's a new senator. She had been a representative in
Senator Phillips Hill. Senator Kristen Phillips Hill.
That's what it is, yes. And the rationale that they presented in their co-sponsorship memo is that integrating behavioral health with physical health would lead to better coordination of physical health and behavioral health. And it would also reduce administrative overhead and lead to millions in savings. And we think that that's inaccurate. And I'll tell you some of the reasons why. But clearly, one of our concerns is that the way they've written the bill, they would simply eliminate the county's role. And so right now, if somebody has medical assistance in Cumberland County, on the behavioral health side, there is no choice. The managed care partner we've teamed up with, Perform Care, manages their behavioral health benefit with oversight from CABHC. And as a reminder, Brian and I and Linda and Andy all sit on the board of directors of CABHC. So we have pretty direct control of the program. For the physical health benefit, Cumberland County resident with MA chooses between, I think, 3 or 4 different physical health MCOs. And if they don't select one, then one is selected for them. And they manage their physical health benefit. If this were changed, the same thing would happen with the behavioral health benefit. It would be split across those 3 or 4 managed care companies, insurance companies, and that would make our attempts to coordinate with them all the more difficult. I can tell you when we work with people who have private insurance, it's a lot harder for them to access their drug and alcohol and their mental illness treatment benefits through commercial insurance than it is through medical assistance. And so that's a concern. The PowerPoint notes that every behavioral health advocacy group in Pennsylvania has supported county involvement in managing behavioral health for medical assistance recipients. And they have since band together as part of a coalition to oppose these bills that have been introduced. The push to do this is coming from the insurance companies. The experience in other states that have what's referred to as a carve-in model is that The result is higher profits for the insurance companies and less care, less behavioral health care for folks seeking treatment for a substance use disorder or a mental health disorder. I can tell you that, especially speaking from the drug and alcohol perspective, it doesn't take much to discourage somebody with an addiction to not seek help for their problem. A hallmark of a substance use disorder is denial. And if there's any kind of roadblock put in front of somebody from accessing treatment, it's a great excuse for them not to follow through with a promise to whoever, their spouse, their family, their employer, their probation officer, to get the treatment that they need. And so that's one of the concerns that we have, that it's real easy to deny care or to frustrate access to care for somebody with a disease like mental illness or substance abuse that has a stigma attached to it and that has denial as part of the issue. So that's part of our concern. I also wanted to remind folks that we had a little bit of taste of what this might be like. When Pennsylvania first opted into medical assistance expansion, now 4, maybe going on 5 years ago, it was under Governor Corbin. But there was a plan to manage the MA expansion population differently than the rest of MA, and to manage that through contracts with private insurance companies. It was referred to as Healthy PA. And for the 9 months that that was in existence, it was really hard to get somebody into treatment. Part of it, I think, was due to the very rapid ramp-up of the program. The insurance companies that had the contracts didn't have a network of providers, mental health and drug and alcohol treatment providers in place. However, they were still receiving a per member per month payment for managing their behavioral health care, despite the fact that they weren't prepared to actually deliver any care. And we're concerned that, once again, when the net result of not providing care is greater profit, we're concerned that they won't have the best interests of our citizens in mind in managing the program.
So the companies, even that were charged with responsibility, essentially were not in a position to succeed.
Right. And part of that, I think, is the fault of the state that we're trying to roll out too rapidly. But the insurance companies accepted the contractual obligation as well.
Let me ask you this question. You don't have to answer, but I'll use it with a quote from our dear department front that scenario. Clueless, calculated. What's the other one?
Good question. That's a good trivia question. Well, I think that I'm going to guess that a lot of these clues. Again, it was the chaos of trying to ramp up very short.
Careless was the third. Clueless, careless, calculated.
And there could have been a little bit of both, because there was money to be earned. Now, of course, that was when Governor Wolf came in. There were lots of complaints about that arrangement, and he scrapped that plan and replaced it by putting the MA expansion population into the same pool with the rest of the MA recipients. So the program that we manage now includes those folks who have MA because they're part of that expansion population. They fall between 100% and 138% of the federal poverty level. So they're not part of the lives that we're responsible
A
for.
lot less complicated than the scenario under Healthy PA.
Yeah, there were
There
additional
are a lot of
requirements.
hoops and hurdles, and as you mentioned, we while we get people into treatment.
And I'll remind you that a lot of those people in the MA expansion population, prior to MA expansion, counted on us to pay for their treatment, which is why we always ran out of money around February for our more expensive orders of care. And that hasn't happened since we've gone to MA expansion as part of the regular health choices program. So some interesting differences in the way the health choices program works right now. On the behavioral health side, it is a risk-bearing program. I think you folks know that. We have had to pull together lots of reinsurance, a pretty significant risk and contingency fund from surplus monies in the early years, because when we get an allocation, it's all we're going to get. And so if the cost of treatment exceeds that allocation, we have to cover that loss somehow. But if it comes in lower than that allocation, we can retain a surplus, but only up to 3%. That surplus has to be used, though, for reinvestment programs that expand or strengthen or improve somehow the mental health and the drug and alcohol services in our 5-county area. We can't use it for building bridges or as profit or something like that. It has to be reinvested back into services. On the physical health side, there is no thing considered surplus. If there is money that they're receiving in excess of the payments, the per member per month payments, that's profit. And there is no cap on that. So it's a very different world already between the behavioral health side, which is basically a nonprofit way of managing, and the physical health side, which is for-profit. And again, there's a strong incentive to minimize the actual services delivered. In the insurance world, a key concept is medical loss ratio. I learned that when we first went to school on how do you do managed care. And they said, this is really important, you got to get this. So I took really good notes on it. And what I came to understand was the medical loss ratio is what you project the cost of your service is going to be. And if you come in above that, you're in trouble because you're losing money. You're swimming in red ink. If you come in below that, the difference is your profit. The medical loss ratio in our world is the cost of the services that we provide. And our goal with our citizens is to maximize their access to services that are well managed and that they meet the clinical and the medical criteria for.
Jack, if you know, with this legislation, the way it's being proposed, what is it about it that's going to improve the process that we have today? Is there really something more to it, or is this a lobbying effort by certain interests?
I think it's the latter. That's why one of the things that we have known is that from the start of Health Choices 22 years ago, the physical health insurance companies have not liked the fact that there's a carve-out, because in their commercial programs, they make a significant amount of profit over managing the behavioral health benefit. And so there has always been an ongoing effort to do away with the county's right of first opportunity to manage and to hand it all over to the insurance companies. And this is just the latest effort to do that. Now, I think that the legislators who have championed this may have just heard the broad talking points. Let's integrate care. If you just hear that, that sounds like common sense.
It does.
instead of two, you're gonna have one, you're gonna have better integration. There's folks who have behavioral health problems, have a lot of physical health problems, and so you're gonna be able to better manage both of those. I think they just got the broad talking. I don't think they have an understanding at all of the county's role in managing behavioral health services. So I think they were sort of sold a bill of goods. And I know that this may be on another slide, that they circulated their bill, their co-sponsorship bill, and they had a handful of people sign on. But
Any locals?
no, none of the local. Jim, I think you checked this out.
Yeah, I was prepping a little bit for the meeting, but there's two bills that were introduced. One was introduced in the House on February 1, this House Bill 335, and another bill identical word for word, was introduced in the Senate on February the 2nd. It looks to me as though none of the members of our county legislative delegation have signed on except for one.
Oh, really? Is that right?
It looks like Senator Ward has co-sponsored the bill that was introduced by Senator Phillips Hill. Now, again, I don't want to be critical of any of these members. They may have, this is why we're doing this, because it sounds better, we're going to consolidate things.
If you read the co-sponsorship memo, it sounds correct.
But it comes down to this, and I, worked in the Senate for over 30 years. Where did the idea come from? Okay. Where did the idea come from? Did it come from the insurance industry? You better believe it came from the insurance industry. And this bill, in my opinion, and I've seen lots of legislation for a bunch of years, this legislation is signed of, by, and for the insurance industry, not for the people. So I think what we need to do is educate our legislators that, you need to listen to the counties who've operated this program successfully. We're meeting our needs. By the way, Jack, I thought that you had an excellent guest editorial in the Sentinel, and I wanted to compliment you for that. A lot of the things we're doing here in Cumberland County, whether it's the Warm Handoff Program or the Opioid Intervention Court and all the steps, those things we probably would not have been able to move forward with had we not had these resources made available through. And, as we heard yesterday with Judge Brubaker, it's working, We have 85 participants in the opioid intervention court, and they're all still alive. That's the bottom line. They're all still alive. And we had a significant reduction, 40% last year versus the year before with opioid drug deaths. So I think we're making progress. We're demonstrating we're making progress. And the last thing we need is for the insurance industry to come in here and mess it up. That's my opinion, that's my personal statement. But I do think that we need to, and you're not finished with the presentation, so I'll let you finish up. But I just think we need to educate our legislators as to the potential negative consequences. There was a piece that was put out by the County Commissioners Association in Pennsylvania, and it kind of I think it hit it all. It says, lawmakers need to understand that one size does not fit all, okay? And how many times have we heard that when it suits the purpose, all right? One size does not fit all. But it says here that the behavioral health choices, the carve-out, has earned bipartisan support from the Ridge, Rendell, Corbett, and Wolf administrations and lawmakers for 21 years because it's working. Okay? And then they went on to say that we know from experience with a pilot project that a carved-in model will result in higher profits for MCOs, managed care organization insurance companies. It will not lead to better care during the pilot. During the pilot, according to CCAP, I've asked for more information on this pilot. during the pilot, at least half of the taxpayer-funded behavioral health payment did not reach the consumer, and instead became part of the MCO's profit margin. Okay, so that should be an alarm bell right there.
Absolutely.
So again, I think, again, I'm not going to make a judgment as to why legislators introduced bills. I'm sure they were given some broad, positive talking points about how this is a great thing, but
what we did learn is that this coalition that has been pulled together, and CCAP has been in the middle of helping organize the coalition because of the county's interest in this. They have already approached folks who have signed on as co-sponsors. And for the Senate bill, there were really only 2 co-sponsors in addition to the primary sponsor. And my
I
understanding
got the
is
bill here with the co-sponsors listed, the latest version. And the way this works, until it's brought up for consideration, members can join the co-sponsor, and then before it gets action, the names can be added to the
my
bill's
understanding is
co-sponsors.
that the 2 co-sponsors have chosen to withdraw their names.
Oh, really?
I know one for sure.
Yeah. And then on the House bill, there were 10 co-sponsors, and thus far 4 have decided. So I think that is a positive sign. Usually, the sign of whether a bill is going to succeed or not is the number of co-sponsors. And when you have very few to begin with, and then that starts to shrink, that's a good sign in our favor.
Okay. Well, and I think that's what's going to be important, is to educate all of our legislators before they consider signing on to it, and hopefully help to convince those who have sponsored it to withdraw. That would be good.
Let me see what else I have for you. Oh yeah, I thought this was an interesting comparison. For our 5-county program, our administrative overhead in the 17-18 contract year was 9.2%, which is pretty good. We're proud of that. That's been a major goal of ours. The course of the program is to reduce that. In comparison, with the best information we have, and it's not easy to get the information because they consider it proprietary, we believe the administrative overhead for the physical health MCOs is between 12 and 15%. So the other thing I want to point out is that the argument is give it all to us and it will be integrated. But with commercial insurance companies subcontract out the behavioral health benefit to other MCOs anyway. And so they don't really keep it. They give it to somebody else. And so it's not really integrated. It's not managed by the same organization. So it's, even on the very face of it, it's misleading. I also wanted to point out some of the things we would lose if we lost the opportunity to manage. Part of our cost of being involved in managing CABHC and in managing the program overall is that we receive a small percentage of that administrative overhead. But for the 2-county area, it's over $323,000.
Pretty big deal.
And that pays for staff, time, benefits, expenses, rent, utilities, indirect cost, mileage, those kinds of things. That is not having to be picked up by the county's general fund. And then, Andy, you can probably best speak to this. There are also some cost reimbursed or program funded mental health programs that reach everybody. And because they reach medical assistance recipients and non-MA recipients, we've come up with some creative alternative payment arrangements.
That's right, yeah. Every year we analyze our crisis intervention data. So we ask for an unduplicated number of citizens served from the previous fiscal year. And from that, we analyze it against claim data from the current fiscal year to come up with a calculation of number of MA eligibles. So this year, in fact, that's what I was just doing, was speaking with Geisinger, Crisis Intervention. They received a prorated amount from Perform Care of $23,000, little over $23,000 a month. So annualized, it's over $282,000 that goes to Geisinger to help offset some of the expenses of the program. Many years ago, that crisis intervention program was solely funded through county MH dollars, and it's about a $1.4 million project. And 24/7 kinds of services tend to be expensive, and we have that in 2 locations, crisis at Geisinger Holy, as well as there's a satellite here at Carlisle Regional that Geisinger operates. So, and then we also have psychiatric rehabilitation services. It's about a $500,000 contract for our office, and the APA amount also helps to offset the expenses of that program as well. And they track the number of citizens being served, an unduplicated number, and that helps us to offset the county expenses so we can let that county dollar do more in the community, which we think is a great thing.
So just between these 2 areas, that's about $1 million in resources coming to Cumberland and Berry counties.
Yes, that's significant.
We would also lose reinvestment funding. And here I just have a broad figure from the 18 years that we've been doing health choices. And remember, in some years there is no reinvestment funding. There's some years we've lost money. We've had to dip into risk and contingency. In other years that we've had a surplus, we can keep up to 3%. But for the 5-county area, it's been $30.7 million that we've been able to put back into various mental health and drug and alcohol reinvestment projects. Some of it's housing, a lot of it's other forms of recovery support. We've developed new programs that then we build in as supplemental services. We have used this to implement evidence-based practices within our treatment programs and our case management programs. And so that's been a big benefit to our 2 counties and the full 5-county area as well. I guess that's all I have for you. So, questions?
Does anybody in the room have any questions? Stan,
I guess I have one
Yeah.
question. Is there, Jack, since we've mentioned the 5 counties here and the interest is in having some type of legislative response and should learn about customizing, is there any value to us potentially making our response to the delegation for the anti-dualage a shared effort thing? Do you think that would be received? Do you think that would strengthen the initiative, or should we do our own thing?
Well, good question. I think that I think legislators are mostly going to hear from the people they represent. And so I guess my gut feeling is that if each set of commissioners communicates with their own legislators, that might have the most.
It's sufficient. It's certainly going to be easier. So
Yeah, and the logistics.
Yeah, so we're trying to get everybody to sign the same thing on.
And you might have a domino effect. As soon as one county does it, the others should follow.
we can certainly share whatever we do.
Yeah.
Yeah, absolutely, and I think that,
Yeah, good idea.
I mean, Dauphin County gets it, because Commissioner Parker did an editorial this morning on the same
Oh, did he?
subject,
Good.
so,
Good.
yeah, I mean, it is, I think that we probably have a good collection of support in opposition to this legislation from probably all the counties surrounding us.
One of the many materials that I gave to Jen, I want to apologize if I flooded with too many handouts, but there's a kind of a sample letter that she has provided.
I saw that.
That we could use as a template.
Jack, could you work with Samantha and maybe put together a draft, or with Amy, or
Yeah.
Annie.
Word.
I'm sorry.
Start singing. So tomorrow.
This is what happens when you get old. Anyway, if you could all work together, put a draft of a letter together for us to send out to our legislators, and then maybe we could, and I do think we should share it then with our surrounding counties, and let them know, and CCAP naturally, I think, too. But, yeah, I think the important thing is to hopefully stop this before it even comes up for consideration, you know. Now, somebody might be selling this as this is going to save us money, right?
Absolutely.
And I think we need to be, prepared to refute that, because that's not what this is about. I think this is more about how much more money the insurance industry can make as opposed to actually saving money. So
folks are digging into the complications of trying to undo it would take contractually the better part of 2 years because of the lag time in getting out claims, the time it takes to reconcile claims. But there's also, it's just false information. They have this thing built in MCO tax, and it gets applied to the behavioral health managed care companies. It also gets applied to the physical health managed care companies. If physical health did everything, they can't tax them twice, for behavioral health and physical health. So they would lose millions of dollars in revenue by not having a separate behavioral health system. So the devil's always in the details, right? And these details are proving that the claim of savings is false.
Let me ask a related question, but not entirely related, which is every factual argument you put on in front of us makes absolute sense, but we all know that we're politics, that sometimes the facts are primary, sometimes they're not even secondary. So I want to revisit this question regarding the co-sponsors. You've mentioned that you've observed this trend that number's starting to contract. If this is financially driven, I would venture a guess that there'll be a concerted effort on the opposition's part to find substitute co-sponsors. And I would imagine they would probably not find that too difficult. So are we able to monitor this and determine if there's an inflection point at which we start seeing new co-sponsors come on board?
Yeah, there are some folks working closely with CCAP. They have employed some consultants through their ComCare program who are keeping a close eye on this. One of them is Pete Shelley from his marketing firm, and the other one is Brad Schopp, who's a paid lobbyist for CCAP, who's keeping an eye on this. And then, of course, Doug Hill and Brenda Penyak, this is primary on their radar screen as well. So it is being watched. I think my understanding is that the next likely step is that budget hearings are starting to take place, and that questions will be presented on this issue. Because the fear is that this could become an 11th hour deal.
That never happens in Pennsylvania.
If the governor wants one of his pet projects, then if there's enough on the other side, maybe we can make a deal on this.
Well, see, this is, I'm looking at the co-sponsorship memo. This is what people have to do. At the very end of the co-sponsorship memo, it says, please join me in co-sponsoring this important legislation that will improve health outcomes and lower costs in the system. So it's going to come down to who does the best job at lobbying and how this is portrayed. You know, if all of a sudden they can put in the budget, okay, well, we can save $30 million here, that's what they're gonna be, somebody's gonna be. The question is that savings real? And I don't think it is. I think that, you know, but this is what we're gonna have to be prepared to go back and say, no, this is all about insurance industry profits. This doesn't have anything to do with saving money for the taxpayers of Pennsylvania. So, I mean, that's kind of, I think, where the argument's gonna need to be made. But I think we're a good company with a lot of groups in other counties around the state, and hopefully we can prevent this from happening. And again, I agree with Gary, gotta keep an eye out. Like you said, though, you know, we have to be, I don't want to use the word loud enough, but we need to make our opposition as well known, because anything can happen at the last second. Or something gets slipped in the thing just to settle, you know, the budget for the year or whatever. You know, so we saw last year, the year before, I believe, where they tried to, there was this effort that we found all this money in all these little pots, and we can balance the budget by just taking that money, you know, even though it was all dedicated to things like 911, and farmland preservation and a lot of other stuff. So we just got to be careful, got to keep an eye out for those kind of, you know, raids, or I think that in this particular case, it would be essentially an attack on a system that has worked actually, and is working to save lives and help people with mental illness and drug and alcohol problems. And, you know, by giving us the ability to shape the program that we need in our community, as opposed to, you know, what the state tells us we need, you know, or what somebody, you know, somewhere else tells us we need. In the case of MCOs, I'm not quite sure what their motivation is. So.
I go back to the one size fits all. It does not work that way. And that, the op-ed that I did, I was asked by RC Cap affiliate to do that with this issue in mind. And that was the main theme of that as well, is that health choices, by giving counties the management role, allows us to develop programs as appropriate for our area, for Perry County, for Lancaster County. You know, what works in Philadelphia doesn't work around here. So.
Well, it was well done, Jack. I got a lot of compliments about it. So.
Thank you.
It's a very good presentation.
Thanks.
That's it.
So next step, we'll put together a draft letter. And
You good with that? Sounds good.
thank you very much.
Andy, I'll remember your name the next time. Sorry about that.
Do we have any other business for finance? Is there a motion to adjourn? So we're adjourned. Thank you.